To AETCM, the emergency medicine channel. Ma'am, today we are going to discuss about an 47-year-old male who came to the emergency with a case of Priapism. A 47-year-old male with a patient presented to the ER. In the triage area, the patient had vitals of pulse of 84 per minute and respiratory of 18 per minute and saturation of 98% and BP of 130 by 80 mmHg. As per the triaging, it has been triaged into green area. So we have taken to the patient to the green area, ma'am. And coming to the secondary survey, patient is a known case of type 2 diabetes mellitus, hypertension, hyperuricemia, and on regular medication for the same. Right now the patient has come with complaints of priapism since morning 2 a.m. It has been 16 hours he has been having this event, at present event.
What is priapism?
Priapism is the erection of the penis with soft glands and urethra.
Erection of penis without, it is actually painful erection. It will not be normal.
Painless.
It can be painful, painless. Mostly it will be painful. It will be very painful if it is ischemic. So it is mostly priapism means painful erection of penis with
soft glans penis and also the urethra. That there is no erection of the glans penis and urethra.
And there will not be any sexual desire.
In the absence of sexual arousal.
Okay. So this happened at 2 a.m. that day.
And he had come to our ER at afternoon 2 p.m.
Was he having pain?
At present, he had been visited by outside hospital and had come here. So there is a reduction in the pain. No pain at present on arrival to our hospital. In the past history, the patient has a recurrent priapism since last October with episodes lasting usually for till 5 hours, usually the episodes. And 2 days back also he had similar history of the event, and for which in the outside hospital they had done a conservative kind of a treatment, and there has been detumescence when they had been treated in the outside hospital. But this event, it had been lasting for last 12 hours plus.
Okay. What all can precipitate priapism?
Priapism as such in routine practice, like right now because of injection of the vasoactive agents, it's being more common, like phentolamine or papaverine type of injections.
PG-even injection. Was any PG-even injection given from there?
During his evaluation of the priapism, for evaluation purposes, he had been injected for PG-even, and Doppler study has been done during that course. But as such, not any treatment. He hasn't taken as a treatment.
Okay. So any treatment for erectile dysfunction or any test like a PG-even injections or papaverine, this can precipitate. Then
the other thing most common is the sickle cell crisis. Patients of sickle cell anemia usually have this in multiple recurrent episodes can be present. Apart from that, medicines like alpha agonist, prazosin, antihypertensives like hydralazine, these all can cause side effect of this. Apart from that, even antipsychotics also has a minimal side effects of priapism. Apart from that, abusing like cocaine abusers can have this as a side effect.
Okay. Then
regarding this
so
case,
what all we told, most common cause of priapism is idiopathic.
Yes,
Mostly it is idiopathic. And then comes the secondary causes of priapism. It can be either because of any sickle cell disease or any other hematological abnormalities. What other things can cause hematology?
Leukemias and myelomas were most commonly
myeloma, thalassemias can cause. Then that is the hematological abnormality. Then secondary to treatment that we have already discussed. Then antihypertensives like
hydralazine, prazosin,
and sometimes calcium channel blockers can also cause this one. Then any drug abuse like cocaine, ecstasy, anything. And
then central nervous system involving, like if there is any spinal stenosis, spinal cord injury can present with that, or genitourinary trauma like straddle injuries in those patients, it can be presenting completely.
Malignancy can cause.
And even toxins like black widow or scorpion bites can present with priapism.
Okay. And you told this patient had hyperuricemia. Sometimes gout hyperuricemia can also precipitate priapism. Okay. Okay.
Regarding to this case further, in the history part, it has been recurrent presentations, and usually the patient had been observed for 4 to 5 hours. It has been there is detumescence achieving within the 4 to 5 hour period. But this is the first time the patient had a prolonged history of not achieving detumescence. That's why he has been referred to our hospital. So on initial local examination, patient had tumescence and glans was not erect as compared to rest of the penis, and there was no tenderness or no signs of edema, no inflammation or gangrene, any signs of that right now. Apart from that, systemic examination wise, patient had no any other complaints.
Okay. So what do you think this is?
To
Ischemic
further
or
workup, in regard to the further workup,
With initial presentation and history, what do you feel this is?
as it's a recurrent phenomenon happening, and it can be non-ischemic because of a recurrent phenomenon, and non-painless. Usually he did not complain of any pain.
Okay. So what is the broad classification of priapism?
We can divide it into ischemic and non-ischemic. Ischemic would be most commonly painful, and non-ischemic is painless. And there is another like in sickle cell anemia, there can be recurrent causes, but sickle cell usually causes ischemic kind of.
Both can come, but mostly it will cause ischemic priapism. Okay. So which is high flow, which is low flow?
Ischemic is actually a venous obstruction causing priapism, so that's a low flow priapism, and non-ischemic is because of a fistula connecting the arterial and venous shunts in the penis, so it will be an high flow.
So the cavernosal artery and the venous system will have a AV fistula like a connection that might be causing the non-ischemic priapism. That will be recurrent also. Okay. And it can be secondary to a trauma. This fistula formation might be secondary to a traumatic cause. Okay.
So in this case, as per the management, as a patient is having tumescence, first the patient has already been receiving pain medication in the outside hospital when he had received. Here the pain score was only 3/10, so we didn't offer any pain management. Next coming, terbutaline is the first choice of agent which can be tried, beta agonist. Beta agonist can be tried.
So this patient, what is required in this patient? This patient is not having any painful erection is not there, and this patient no tenderness is not there. So we are considered as non-ischemic. So what is the management from the ER?
From the ER, we would initially, to differentiate ischemic and non-ischemic, a Doppler study can be done, or a local blood gas analysis of the collected blood we can withdraw and run it. Depending on that, we can differentiate whether it's an ischemic or non-ischemic.
Non-ischemic.
But in this case, as the history was, it was suggesting us to be non-ischemic, but when we drew the blood gas, we got the pH to be 7.046 with lactate of 8.8. Showing metabolic acidosis picture, like as if ischemic kind of a picture. So we consider it
PO2?
PO2 was 16.5.
Okay.
So we consider it to be initially because of the ABG and ischemic kind of a picture, and we had to go further with the evaluation. So we had
we have patients with ischemic and non-ischemic. So this patient had recurrent histories of non-ischemic priapism. Recurrent priapism he was complaining also. When will a non-ischemic priapism will change to an ischemic priapism? After how many hours of erection?
4 hours usually.
Okay.
Because of the stagnant blood, the pH of the blood drops, and there can be clotting of the blood, because of which leading to thrombosis of the veins and causing fibrosis further.
Okay. So this patient, we have checked there was metabolic acidosis, lactic acidosis was there. So what is the cutoff? If we are seeing a PO2 less than 45 or a PCO2 is more than 65 and with elevated lactate, we need to consider it as ischemic. Okay, so how did you aspirate blood for taking the cavernosal blood gas?
There's a procedure, like we start with the installation of local anesthesia at the base of the penis. We can give either ring block or the dorsal side to block the dorsal nerves. After that is done, a sterile.
So how will you do that?
Using 27 gauge needle, but we need to be careful that we should use only lidocaine, not with phenylephrine or adrenaline.
So plain lidocaine
lidocaine has to be used
should be
for the
used.
block.
1% lidocaine. We should avoid adrenaline. Okay.
After then we can.
So base means both sides. So,
Yes, ma'am. All the sides around the base of the shaft of the penis we can infiltrate, or just majorly as the nerve supplies to the dorsal vein, dorsal nerves, dorsal side of the penis can be infiltrated.
okay. So there are actually dorsal nerves and ventral nerves also. So our focus is where is the blood collected here?
Here it is collected mainly in corpora cavernosa.
Cavernosa.
Both
That is the
sides.
thick shaft of the penis. Okay. What is corpora spongiosum?
Spongiosum would be in the ventral side of the single aspect which
single-
is having the urethra.
And it is covering what? What part?
Penile urethra.
Penile urethra. So urethra is in the ventral part and this spongiosum is in the dorsal part. So we need to only anesthetize the dorsal nerve. So where will you insert the needle for giving local anesthetic?
We keep the dorsal we palpate the dorsal aspect as 12 o'clock and 2 and 10 o'clock. Any one side we can prick. Because there is continuous communication between both the cavernosas, only one side prick is enough for the.
No, for giving dorsal nerve block, you need to prick both the sides. And you will have to insert either 3 o'clock or 3 o'clock, 9 o'clock or 10 o'clock, 2 o'clock position. You will have to insert the needle. 1% lignocaine should be infiltrated and a wheel should be formed around. And sometimes if it is less surgical procedure and all, and if you feel a ventral block is required, you will have to give ventral block from below also. But in our case in the ED, mostly we will be just aspirating. So dorsal block is only required. So a ring block, as we give a ring block, we should give anesthetize the dorsal nerves. Okay. Then after that?
After that, we'll introduce a butterfly shaped needle
No,
IVC.
I asked how do you take ABG.
ABG, we take the ABG syringe. We have to go through the skin, subcutaneous tissue, and tunica albuginea. These three superficial layers at 45 degrees, we insert the needle, and superficial itself, once the blood is.
How much centimeter you will have to insert in? Only half centimeter might be required. If we penetrate more, we will be penetrating into some
arterial
other
supply of cavernosa.
So at which angle or which o'clock position you need to insert?
2 o'clock or 10 o'clock we have to insert, and it should be from the proximal aspect, it should be 4 to 5 centimeter from the shaft of the penis.
So why not in 6 o'clock or 12 o'clock position?
12 o'clock position, it would be the dorsal side, it will not be any cavernosa. 6 o'clock would be spongiosum.
So 12 o'clock position, there will be vessels and arteries and veins supplying the penis. So we can't penetrate to that area. Below that area will be the urethra is passing through the 6 o'clock position. So rest all areas from 3 o'clock, 10 o'clock, these positions are free. So we will have to insert it 0.5 centimeter only we need to insert. That depth is only required. More than that we might be injuring into the some other vessels. For giving block, dorsal nerve block, you need to prick from two sides. But while taking a ABG sample or while aspirating the blood from the corpora cavernosa, you need to prick only one side. Why?
Because they are intercommunicating.
Both are communicating. Okay. So what needle will you use for aspirating?
For aspirating ABG.
ABG,
We use a 26 or 27 gauge butterfly cannula for aspiration, and for this also 26 gauge needle for ABG also.
Okay.
It's finer gauge.
Textbook says 19. Okay. And we need to stabilize that because we are inserting only a very 0.5 centimeter only. So we don't want that to come out or we don't want to go in. So we need to stabilize it. So that's why they are telling butterfly. Butterfly will be small and it will be there and it will be slowly draining
without
blood
major
through.
suction force. It will itself be draining.
What will happen if you give suction force?
It will inhibit, it will obstruct the flow. Because of the clots formation usually in the ischemic, it will not be free flowing.
Okay, so it should free flow spontaneously. It should flow.
Or we can massage that and we can milk it out through.
Okay. Then So that is the first step. So when all will you consider as draining this cavernosal blood?
Initially, first we give medical management for the
First we can give any systemic analgesics. So first we need to
Opioid.
differentiate a patient whether the patient is having ischemic priapism or non-ischemic priapism. So any patient, if the patient is having non-ischemic priapism, our role in ER is just to observe the patient. Non-ischemic priapism. Ischemic priapism, if you are suspecting, the patient will be having severe pain will be there, that penis will be tender and it will be erect. In that case, we will have to, if we are suspecting, then we can take an ABG from the corpora cavernosa and confirm it to be ischemic, and then we will have to consider draining. For draining, as we told, we will be giving a dorsal penile block with 1% lignocaine. Then we will be proceeding with the drainage. Drainage, as we told, a butterfly needle will be inserted at 10 o'clock position, or 10 o'clock, 2 o'clock, or 3 o'clock, or any 9 o'clock position, and we will be allowing it to drain. Then even after draining, if you are feeling any block or if it is not completely coming, you can irrigate. Irrigate means we can give some saline through that and we can wash it out. Okay, that is the first choice. That will reduce the pain, and that is also the treatment also. If that is not working, then what is the agent?
we can instill some vasoactive compounds through the syringe itself, like phenylephrine. We can dilute it 0.5 10 mg.
So what is phenylephrine?
Alpha
Alpha
agonist.
Agonist.
Alpha.
So what will alpha agonist do?
That will cause the increased blood flow basically.
Priapism came because of increased blood flow.
The local blood flow.
It is actually vasoconstrictive agent, so it will reduce the blood flow. Here the problem is increased blood flow. That's why the penis is erect.
Yes.
So we are trying to drain it out, and we are trying to reduce the blood to that area. So we are giving these agents to reduce the flow to the corpora cavernosa. Okay. So how much should we give?
Phenylephrine actually 0.2 to 0.5 mg is diluted with saline.
What is the dose to be given?
To instill it, 20 to 50 ml is instilled.
No. What is the how much is the dosage which is required in micrograms? 100 to 500 microgram. Microgram is
yes.
That should be diluted in normal saline, and it should be given. Okay. And how will you repeat? How often will you repeat?
First we instill it, wait for 20 minutes, and then we
5 minutes. 5 minutes is required. After 5 minutes, we can give it again.
Maximum to 1 mg only we can
give. So 100 to 500 microgram can be diluted and should be given through the corpora cavernosa, and then it should be repeated every 5 minutes. Okay. Till
the maximum dosage of 1 mg.
And what is the ultimate result we are expecting?
Ultimate result in this case would be that when that dark venous blood will be, if we have to be taking it out, and once the bright color red blood is coming, then we can stop, or if the detumescence is achieved.
Okay. Then when will you involve urology?
In non-ischemic cases, we have only observation and we have to give to urology to repair the shunt. But in ischemic cases, if the detumescence is not achieving even after instilling vasoactive agents also, then they might be considering to place a shunt or surgical procedure for.
Okay. Then if that is also not working, if phenylephrine is not working, what will you do next?
Urology.
Urology consultation and
hematology also to
that is for evaluation. Then even
shunt.
distal shunting can be planned in case of ischemic priapism. Okay. And if it is non-ischemic and if it is secondary to an AV fistula, then we can consider doing embolization. Okay. Then what all blood tests will you send if it is ischemic?
If it is ischemic, we need to rule out hematological causes first. First thing we used to do is drug history, to evaluate for the drug history, and second would be the hematological causes to see if the clotting time and the coagulation profile and the same to see that. Apart from that, even a Doppler study can be done to see whether it's an arterial or venous, which flow of that.
Okay, and all the workups for the coagulopathies, hyperuricemia, then malignancy workup should be done. Okay, anything else? So for this patient, what was done?
For this patient, as patient has been
initially he was non-ischemic, came with ischemic. Okay,
and later a Doppler was done, which was showing an non-ischemic arterial supply was present in the Doppler, which was done. Right now he's being evaluated for the same. He's been admitted under urology for this.
Okay, thank you.